Good morning, my teachers. God bless you. God bless you. We will start with a prayer as usual. May all those who are afflicted be affliction free. May they be serene through all their ills. Silence, please. Even if bodily afflictions do not subside, may we all be healed in heart and mind. Friends, what we are going to discuss this morning, fresh from sleep, is really nail-biting. And this is what happens to us many times in our life. As obstetrician, Mandade madam will bear with me. Pushpa madam must be a master of that, and she must be running like me to many places where you are called. And that is near-miss situations. These are very dangerous. Those situations which kill. Now what Bhaskara was telling was a near-miss situation, preventing a near-miss. That which kill is over, finished and done and dusted. Then whatever you face, that's okay. But the near-miss are very dangerous. And what's a near-miss situation? This is not an exam, please. So I'm not going to keep it tight, and I'm very poor examiner because I hate exams. Okay, I will myself define it to make work easy. A maternal near-miss is defined by WHO as a woman who nearly died but survived a complication that occurred during pregnancy, childbirth, or within 42 days of termination of pregnancy. I am repeating what the dialogue of Sholay which I put yesterday, and that was Jo dar gaya so mar gaya, that will be coming now, but ye bhi bach gaya. That was a dialogue. And that is where he tries to shoot and the bullet doesn't come out. Ye bhi bach gaya, and many times we feel this. Ye bhi bach gaya. I am sure Bhaskar must be feeling that way. When the diagnosis of VT comes, ye bhi bach gayi. Okay. But handling near-miss situations, my teachers will agree, is very exhausting like this. ऐसा हो जाता है, हम थक जाते हैं हम. And they can be quite challenging. But then I am not afraid because I represent the students, and a student can always, and a fool can always ask more questions than what wise people can answer. And you are my teachers now. This is what you are, and you are going to take us. And this is for Rohini. Rohini is madam's daughter. This facility is available on the mouse pad. You need not show like this. This is available on the mouse pad. Yeah, you are modern people, but we are still agile. Okay. This is me, ma'am. This is the audience. And this is you. You have to take us to how you would have managed this. There might not be a 2 plus 2 is equal to 4 solution. Okay. And these situations come from all throughout the world, mostly from India. And these situations have already been given to them nearly 10-15 days before, so that we get the maximum advantage of our teachers. They are brilliant people. I don't like to corner anybody. I don't believe in violence. This is also mental violence where the chairman or the moderator corners them, tries to show off his knowledge. No, that is not my job. Let us begin. Shall we go? Yes, ma'am? Okay. First two were tricky clinical situations. Rest will be actual management of near-miss. An unbooked patient underwent emergency LSCS for previous to LSCS at a district hospital. Intraoperatively placenta accreta was diagnosed due to hemorrhage, and the subtotal hysterectomy was performed there. It was performed there. 4 units of packed cell transfusion were given. The patient continued to have vaginal bleeding, hence patient was transferred with 4 more units of packed cells. And in this state she was transferred. transferred in crisis. She was going down. On receiving the patient, she had a pulse of 190 per minute. I know difficult to, but then sometimes they can be recorded. BP not recorded, but extremities cold, abdomen was soft, vaginal bleeding was present. 8 units of FFP, 4 units of platelets, and 4 more packed cells were given. Now what? Now what should we do? Anyone can answer, please. You know these situations?
Hello.
Yes, ma'am.
First, please apologize me. My voice is not good.
No, it's okay. Your husband must be very happy. Sunne ka nahi.
Patient, it was a placenta accreta, and she was bleeding inside.
No, not inside. She's bleeding outside.
Outside. Internal iliac ligation would have been done at the same time.
No, but now she comes to you, so you will do an internal iliac ligation.
Okay. First is the internal iliac ligation, and coagulopathy. We have to treat the coagulopathy. So massive blood transfusion protocol has to be given.
Okay. Okay. Any other input? Yes, ma'am.
Yes. Sir, what about the cervix? Was the placenta encroaching on the cervix?
Yes, it was.
Descending uterus.
Yes, it was. Okay, I'll make it little tougher for you. You are very brilliant. Nothing is mentioned on the reference letter.
There is what, sir?
Nothing is mentioned on the reference note.
Yeah, that's why.
मत अभी बताओ ना.
At least.
इसलिए तो आपको पूछते हैं.
At least see was the cervix how.
So you'll put a speculum.
Yeah.
Okay, whether the cervix is there or not. If it is there, it is bleed. A hysterectomy has been done.
Yeah, but the cervix is left behind.
So therefore you are going to see.
Yes.
Okay. Will it worsen the bleeding?
Sir, I think we should pack the cervix first, vagina first, put her on the NAST garment and shift.
No, what is that? Please, no, I don't know it. I am a very average student, please.
Non-pneumatic anti-shock garment should be put to her because she is already.
She is in your hospital already. Now she is not being transferred. Please.
Till she is putting into the OT table.
Okay.
She will be.
OT is ready, madam. You are the boss.
Yes, sir. So I think we should first proceed for the total hysterectomy to her, and if
This has already been done, madam. अभी दूसरा uterus कहाँ से लाऊं? वो दिल कहाँ से लाऊं? तेरी याद जो बुला दे.
total was done, sir, for her.
अच्छा, तो you will go further deep. Yes, ma'am.
As soon as the patient comes to my hospital, first I will evaluate and call for the help of my colleagues,
Yes, ma'am.
my seniors,
You have
and
with
the
you.
anesthetist. I will call for the
Yes,
anesthetic.
very competent in anesthetist. Fair?
Then I will evaluate and ask the anesthetist to and do some investigation. I will send fast investigations.
Which
also.
one?
I will do ultrasound. Ultrasound is there in each and every gynecological.
And what will you like to see?
Setup. In the subtotal
Madam,
hysterectomy.
खोल नहीं डालने का इसको.
No. In
Not
the
opening it up.
So, therefore only,
Where are we
because
wasting
in
time?
subtotal hysterectomy, already the breach in the placenta accreta is at the level of the placental insertion. Placental insertion is usually at the site of deciduum basalis will be broken at the site of the LUS. And therefore, it is needed that total hysterectomy should be done and not the subtotal, and therefore I will go for the exploration
Okay,
first.
madam, you can keep the mic, please. Keep the mic. Madam, keep the mic. This is what they did. Concurrently, patient was taken up for emergency laparotomy and removal of the cervix with internal iliac ligation.
Yeah.
Is it okay? You are happy now?
Yes.
Excellent. Thank you very much. What happened was, no, we have lots of time, madam. Don't worry. Post-operative pulse was 160. Blood pressure was 90 systolic. Patient was given ventilatory support for 12 hours. Patient was well and was discharged in the 10th post-operative day. So you managed it excellently, madam. Thank you very much. Next tricky critical situation. And that is a dangerous looking situation. What is it? A 26-year-old G1 P1 referred from a peripheral hospital to a teaching hospital had persistent bearing down after a spontaneous vaginal delivery. Live neonatal birth was there, 3.4 kilograms, 6 hours prior to presentation at the hospital. She came in this condition. Delivery is over and she is bearing down.
Yeah.
She is in severe agony. What is happening?
Bearing down effort usually comes when the patient came with the inversion of the uterus or the retained placenta.
There is no inversion, madam.
Retained placenta.
There is no retained placenta. Yes,
Sir,
ma'am.
actually it is a sign of a hematoma, sir, which may be developing
Hematoma
inside.
where? Intracranial.
No, sir, a perineal hematoma which may have been
I'm a
missed
bad
during the
student, madam. A fool can always ask more questions than what wise people can answer.
Sir, first thing I would like to do is take her on the table, explore her.
Madam, I have handled Foxy managing committee meetings and I have not allowed it to digress. So please, we will remain on the topic. Yes, please. आप बोलिए, आप अच्छा बोल रही हैं, please.
Sir, I would like to take her on table and examine her first vaginally to see if there is any missed episiotomy sutures or if there is any missed bleeder inside the vagina. If there is a
Be
hematoma
there,
formation.
be there. Our examination revealed a young lady was pale, dehydrated, intermittently straining in response to an irresistible urge to push. Her pulse was 102, moderate volume with a blood pressure of 120/70. Uterus was about 20 weeks pregnancy. There is no question of inversion. Okay, and it was well contracted. And now I am coming to you. The pelvic examination showed a blood smeared vulva with a tender swelling involving the right labia minus and majors measuring about 4 by 4 centimeters. This was the picture. Yes, ma'am. No, but matter doesn't end here, please. Soon she collapsed with tachycardia and hypotension. She was catheterized and anesthetized. Now what?
Immediate drainage of hematoma.
Immediate drainage of
blood
hematoma.
transfusion.
Okay. Hematoma was indeed drained. Hemostasis was achieved by figure of 8 stitches. The space was obliterated with deep sutures overlying the skin, and the vagina was packed to further assist the hemostasis. Is it okay, ma'am?
Yes, sir.
Okay, thank you very much. And this was the bleeding. It could have killed her. Okay. Anything else needs to be done? फिर हो गया, अच्छा है सब, जाने दे अभी उसको वार्ड में शिफ्ट कर दें.
Have to keep her for knowing her coagulation status and all. Because
She is fine. She is not having
Sir,
any coagulation.
antibiotic coverage is again
आज
very
चालू कर दिया
important.
एंटीबायोटिक. सर्विक्स में ब्लीडिंग नहीं है.
Sir, I would also like to do sonography after the patient is stable to
आपकी
rule out
उंगलियां है
if
ना
there is any
मैडम?
associate.
आपकी नहीं, बाहर निकाल देने के बाद, after she is pushed out of the operation theater.
The,
Why, madam? Please take the mic.
Yeah.
Please take the mic. There she comes.
We will like to palpate the fornices also
Why, madam?
and see whether there is any tears or
No, there are no tears, ma'am. Exactly. Madam, you
extension.
take the mic in your hand
yeah.
and speak.
extension of that.
We'll have to look for the extension of.
And how do we look? We cannot go. Are we able to go above the hematoma?
We will palpate through.
If we are able to go above that edema which has occurred, that means it is not extending. If it is going above, then what will you do?
We will not reach up to the upper margin of hematoma.
Yes, then what we should do?
We will have to open
You
the.
have to open it up. Thank you. Excellent. Ladies and gentlemen, give them a big hand. My teachers are doing a fine job. Excellent. Yes, that is the hidden danger there. You can see the hidden danger there. Look for internal extension, and that can even require an internal iliac artery ligation. So these are not easy things. She was put on antibiotics, transfusion of 3 units of blood, discharged on the 3rd day following a satisfactory post-operative recovery. This case came to us from Nigeria. We come to the next. This is where now we are coming to the crisis management. The 2 cases are over. We come to crisis management. And let us manage the crisis. There are 2 patients who delivered in quick succession at your hospital vaginally. Both are having PPH. Which of these will you shift to the ICU? Don't say both, because there is only one ICU bed.
The cause of PPH should be first evaluated.
So we will wait to find out the cause and then shift to the ICU.
No, either this is quick succession and patients requiring medical management of PPH, like atonic PPH, should be shifted to ICU.
But
And
coagulation disorder है और profuse bleed कर रहा है तो नहीं shift करेगी.
She should
Population
be seen for anemia and or other factors. If she
Anemia तो blood का report आएगा तब ना मैडम.
First I will see for the shock index.
But not at the same time, please. No, keep the mic in your hand. You are talking lots of sense. Yes, ma'am.
she is already anemic, she is suffering from PIH or other.
Madam, it will appear pale. In shock, anyone appears pale.
But-
My audience and my students want to know which to shift.
heart.
Yeah,
may I?
there she comes.
Huh.
There she comes.
So, I
Important
will go for
signs.
the-
Yes, madam. Please tell us.
I will first, fastest mode to evaluate for which one to shift to the ICU is to assess for the shock index. See,
Yeah,
for
I am
the
coming
heart
to
rate-
shock index a little later. So, low blood pressure or weak peripheral pulses,
Yeah.
cold temperature in extremities, and peripheral
Altered
cyanosis.
sensory.
Any other warning or critical care signs, madam, which now this is where, madam, yours will come. Okay, a reduced urinary output. Okay, you will agree, please stop me if I am wrong. Okay, I'm just putting my suggestions. Dyspnea or hyperpnea, high temperature,
Yeah.
unexplained fatigue. Shall we shift these? Okay, madam. Chest pain, tachycardia and all will come. Okay. We come to the next, and this is where the targeted attack comes. And madam, I want that madam with the blue sari to take the mic again. And that is where, tell us something about the shock index, madam.
Yeah, sure. I'll see for the shock index. In shock index, we take out the, it's a heart rate divided by the systolic blood pressure. And if it's 0.9 or below, it's reassuring for us that the patient is good and we can manage it. And if, out of the two, if the one is having a shock index of more than 1.7 or 1.5, then
That's
I will
bad.
immediately, it's worst case, and therefore I will immediately.
Excellent. Thank
shift
you
her
for
the-
substantially
Thank you.
adding to our knowledge. Yes, she requires a big hand. Yes, thank you very much. You can clap for her, please. Madam, my shock index currently is 0.5. Pulse is 62, 124 systolic is the blood pressure. In spite of all this excitement and such beautiful ladies around. Okay. Shock index, please, will you agree to this, madam? So accepted value of shock index ranges from 0.5 to 0.7. And shock index greater than 1.1 is abnormal. You can do this while calculating, just examining the patient. Doesn't require any elaborate instruments or anything. Okay. We come to the next situation where the problem goes on and on. Okay, just doesn't stop. You know, मारुति की एक एडवर्टिजमेंट आ रही थी, मारुति की गाड़ियाँ की एडवर्टिजमेंट आती थी, वो पेट्रोल ये गाड़ी रुकती नहीं, पेट्रोल खत्म ही नहीं होता. So this is what happens. It goes on and on. I was giving a trial of labor to a previous LSCS car and attempting a vaginal birth after cesarean section. Labor did not progress, and the patient's general condition also worsened. I opened her up and found a bad rupture. First, I tried to save the uterus but failed. So I did a hysterectomy. Patient was shifted to the ward. As the surgery was prolonged, as usually happens in a very busy outdoor, there was a big backlog at the outdoor. The ward paramedic staff was providing me with the info on vital parameters. All seemed to be going well, and then suddenly the patient collapsed. Everything was fine. I am sure everything is fine. There is no bleeding inside, nothing. I've done a clean surgery, and then I get a phone call. Sir, patient mar rahi hai, bhago.
So
What
there are
must have
two.
Maybe embolism must have happened.
Embolism.
Pulmonary
Madam?
embolism.
Aspiration.
Aspiration.
So there are two
Maybe you are keeping it
parameters
in mind. Could
important
be
here,
embolism,
sir.
could be aspiration.
So previous LSCS who's been undergone a trial of labor and we've already diagnosed as a scar rupture. So an amniotic fluid embolism, though rare, is a possibility that we have to consider. And second thing is, sir, you've also mentioned that she's undergone a long surgery.
Yes.
So again, we are looking at a thromboembolism episode also. Again,
I know, Bhaskar is very handsome and you people like him. And his lecture, I understand. But embolism ko chodo na, madam, abhi. He also said 1 in 1,500.
Yes, so just because it's...
If you think of rare things, you are rarely correct. If you think of common things, you are commonly correct. Am I right in presuming,
Yes. Yes, sir.
that after massive hemorrhage, meticulous monitoring of patient's pulse, because
Yes, sir.
without any reason also she can go in shock. Okay, prolonged surgery or surgery following massive hemorrhage will in itself send the patient to shock. Her cytokines which are managing her homeostasis, I did not wanted to go in this stark academics which I love, okay, but the cytokines which were protecting her system can get overwhelmed by the destructive cytokines and the whole system can just collapse. And that is only because of the surgery itself. And can that happen, madam? Yes. So therefore, I am sure you will tell us that don't leave the patient alone, or at least I did a good thing that I kept that very competent sister to monitor and we rushed down. After hemorrhagic shock has been tackled, the obstetrician should continue to be vigilant even after the vital parameters begin to improve. We are still not out of the jungle. सब अच्छा है, ठीक है, चलो घर जाते हैं, पार्टी करते हैं, एमॉक्स के कल्चरल प्रोग्राम में जाके डांस करते हैं. नहीं होता है ऐसा. हमारी जिंदगी में लिख के ही नहीं लाए हम, नसीब में नहीं लिखवा के लाते हैं हम लोग, इसलिए होता है ये. And there can be, these are systemic inflammatory responses, cytokine mediated, absolutely. If you want, I can give you the number of the cytokines also, the number, and the subsequent septic shock. We are still on to crisis management, and we are on a paradoxical situation. And what is the paradox? I have observed two paradoxical situations at times. In spite of excessive bleeding, many times blood pressure just remains fine. And in spite of clinical volume correction, blood pressure just doesn't come up, respond fast enough. Why does that happen?
Even if
You have seen this? ना इतना push कर रहे हैं फिर भी ऊपर ही नहीं आ रहा है.
So
And-
now urine output has become more important in monitoring a patient's response to our blood transfusion rather than simply the BP monitoring, sir. So
Okay.
if the patient's output is more than 30 ml per hour, I'm happy, sir, even if her BP is not immediately responding.
Okay.
If her urine output is compromised, then I'm more worried about her systems not responding to the blood transfusion.
Excellent. Yes, madam, please.
If there is internal bleeding is continuous, like in ectopic pregnancy, unless
No, there is no bleeding, madam. You do a fine job. There is no bleeding. Still, it is not coming up. Madam, if it was so easy, I would not have brought the situation here. These are near miss ones. Yes, madam.
we are doing clinical volume correction, but it's also important that heart is pumping the blood right stroke volume, because we are giving her preload. If there is adequate diastolic ventricular filling and it is pumping, that means a cardiomyopathy, cardiac problem may be there.
Hi, madam. Hi. Madam, मुझे भी बोलो ना hi. अब उनको ही सिर्फ hi बोलते हैं. Yes, yes, ma'am. Please go ahead.
Cardiac problem will have to be ruled out, means cardiac pumping may not be adequate.
क्या करना है उसके लिए?
Blood pressure. Inotropic agent will have to be started.
Anything else? Something very simple. I know, madam. But what should we do? एक CVP line रखनी है.
एक central line.
Okay, before even without putting a CVP line, would you like to put a CVP line?
Yes.
First and then the
Easy है, madam.
Yes.
बहुत easy है. It is not difficult. Every time you don't require a Swan-Ganz catheter for that. Okay, fine. My input, if you agree with. Fall in arterial pressure during shock states may be delayed. Once again, the same inflammatory response can come in. Vasodilatation can suddenly occur. Severely reduced cardiac output for periods of 40 minutes to 2 hours can occur before a significant reduction in arterial pressure can occur. So up to 2 hours this mischief can go on. On the other hand, another paradox means the answer to the second wing of the paradox. On the other hand, if the fluids are used to restore blood pressure, the cardiac output and the oxygen transport may still be needed to be corrected even if the blood pressure is normal. As you said about the cardiac output very nicely, rightly. Yesterday you told me during lunch that, sir, I come from a very small city. Madam, you are answering such brilliantly. There is no limit. There is no limit to knowledge. There is no limit to knowledge. Swami Shivananda has said at one place, ज्ञान पर किसी का इजारा नहीं है. आप वैसे चमक रही है, madam. May God bless you. May God bless you. Thank you so much. We come to the next crisis management. And that is the mystical PIH. My whole life has gone in PIH. Okay. I love PIH. On one side there is vasoconstriction, on the other side there is edema. On one side there is hypertension, on the other side there is shock. On one side everyone seems to be knowing what is happening, and the other side nobody knows what is happening. This is the hypertensive crisis of PIH. Let's see this situation. A primigravida with 37 weeks with severe preeclampsia and twin gestation was admitted at a private hospital for elective seizure. On the operating table, the patient was detected to have extensive crepitation in the lung fields and 85% oxygen saturation by the anesthetist before induction of anesthesia. What would you like to do at this stage? Shift her? Ask for
first
it.
is
Madam, aap
handle the
aaiye,
surgery.
please.
Pulmonary edema.
Yes, very bad. I am extremely
Very bad.
afraid.
Yeah, and they use Lasix in milligrams, anesthetist, and they clear the things. And the pulmonary edema is the cause for that. So only 85% of oxygen will not work unless diuresis is done.
Okay.
And we have to monitor the output also.
Will you continue with the surgery?
But we have to see the fetal conditions. Now we
Fine,
have to
fetus
continue.
is fine. For preeclampsia, you have severe preeclampsia, you took her up for seizure.
We have to continue the surgery.
In this bad state,
For that moment only we have to stop.
at that moment you will
Only.
stop.
And then
Fine. You stop there, but with the mic. Please take it in your hand. Okay. Surgery was indeed abandoned, madam, as you advised. Furosemide was given, patient was intubated, and help was sought. Was transferred to another. When patient arrived at the tertiary hospital, she had 97% oxygen saturation, along with extensive crepitation still there. She was fully dilated. Should we continue with the surgery?
No, we have to resuscitate the patient
This is
first.
हुआ ना, अच्छा हुआ ना मैडम, 97% ऑक्सीजन सैचुरेशन.
We have to intubate. We have to
इंटीमेटेड ऑलरेडी
resuscitate.
कर दिया ना मैडम, कर दिया. दूसरी ट्यूब क्या डाला?
So at that time, we have to first talk with the relatives.
बात
And
किया
whether
ना मैडम, बहुत बात
we can
किया.
save the babies, then go ahead with
Delivery
this.
should be done.
Delivery should be done at that.
Delivery should be
Delivery
done.
should be done.
Delivery should be done.
We have to operate.
ओके वो बात करेंगे मैडम. वो कम्युनिकेशन का कल पूरा वर्कशॉप था तो उधर हो गया सब. अभी वी आर स्ट्रेट ऑन क्लिनिकल एंड स्ट्रेट रॉ एकेडमी रॉ क्लिनिकल वर्क. Patient was shifted with ventilator, 40 milligram furosemide was given. Assisted vaginal delivery was affected. Vacuum or forceps?
Forceps. We have to see the
Madam, it is
dilatation first.
Fully dilated. I told you
Fully
it is fully
dilated.
dilated.
So it is a
Can we-
forceps. We can.
Can we have a cup of tea? मैडम
No, no,
आपको
it's
जगाना
okay.
है.
नहीं नहीं.
हाँ.
Definitely we can go for both the things.
बट पूरा रोटेशन नहीं हुआ है मैडम.
So vacuum.
Then vacuum. If we see that it is at
आपने
zero
तो forceps
station.
लगा दिया मैडम.
No. If it is at the zero station, we have to go for the vacuum. And if it is at outlet, then even today also we still use outlet forceps.
Good. Yesterday I quoted a figure of 2017 which shows that forceps causes less trauma than vacuum. I don't want to get bogged down into this. We go ahead.
Second, twins hai.
Diuretics were repeated after 6 hours. Antihypertensives were administered. Ventilatory support required for 24 hours and the patient was slowly weaned off it. We are about to finish. A problem? Yes, please. है time.
Here it
ये लोग
was-
भी कुछ नहीं कर सकते. हमारे पास full time है.
Sir, here you mentioned that she is having twin pregnancy. So I will see for the presentation also. Presentation is equally important.
Madam, I am making my life very comfortable.
For
It
the
is
second
vol-
baby.
Both are
whether
presenting
to
by
do
vortex.
Delivery of the first only. Okay.
Madam, both are presenting by vortex. Simple.
So, but even
she
in
can
twins, if the first is vertex and second, even if it is breech, we should be able to deliver vaginally only.
Yeah, only transfers you will go. You will go for internal version.
We should
He
be
is such a
vigilant.
bad patient.
No, sir, not in such.
डरते हैं आप? मैं नहीं डरता. मैं नहीं डरता. Cesarean section is going to cause more trauma. हाथ डाल के खींच लो उसको. You are a master. What is there?
Should be
No
vigilant
problem.
for PPH.
No problem. No problem. No problem.
You should be
No-
vigilant for PPH.
Yes, we have to be. We have to be. Now we come to this. अभी देखो ये. Mrs. I, 26 years old, G4, P1, MTP3, was admitted with intermittently heavy vaginal bleeding. She was talking about drugs, prescribing drugs in pregnancy, and I was waiting for you to tell 2, 3, 4, 5, 6 progesterones in one patient. देखा है मैंने. क्या क्या नहीं देखा. 6 progesterones. Unnecessary, both low molecular weight heparin, same patient. Low molecular weight heparin and regular heparin. HCG, क्या क्या नहीं देखा उसको. तो ये इसमें ऐसा है. 1 MTB, 2 MTB, 3 MTB, 4 MTB, 5 MTB. करते ही जाते हैं, करते हैं. What is the indication for MTP? Before your competitor does it, do the MTP. Hysterectomy also same way. When do you do a hysterectomy? Before somebody else does it. Right? So ये होता है. ये बच्चा जाना नहीं चाहिए. That is the point. ART pregnancy, all physiology goes for the toss. Physiology pregnancy, what teachers taught us, goes for a toss. ये बच्चा मरना नहीं चाहिए. 1.5 लाख रुपए दिखते हैं. 1.5 lakhs का सवाल है. फिर कुछ भी हो जाए. I would have really, I was so much attentive to your lecture. This was an opportunity to make our conscience wake up. This is how you prescribe. This time she was nearly lost. She was having intermittent vaginal bleeding. This case comes to us from India only. She had her last MTB just 7 months ago. At that time she was subjected to bilateral internally ligation. A suspected cervical pregnancy for severe bleeding during MTB procedure. Okay? Are you all with me? चले आगे? स्कूल चले हम. Yesterday एक गाना लगाया था मैंने. स्कूल चले हम. ये स्कूल में ही है हम. No histopathology records available. She remained asymptomatic for 2 cycles and after this she had irregular profuse bouts of bleeding lasting for 10 to 15 days each. What is happening?
Sir, invasive mole may be there.
There is invasive mole. Okay. So we do, okay. I'll give you an ultrasound report. Yeah. Clinically first, She was pale, hemoglobin was 5 grams, per abdomen findings were normal, per speculum examination showed a normal cervix with no congestion, erosion, growth or ballooning of the portia. Per vaginal examination showed a normal sized firm uterus and her biochemical profile was normal. What has happened?
It may be a arteriovenous malformation in the
Okay.
pelvic ends.
Anything else? Mic में बोलिए ना madam. Why arteriovenous malformation?
Multiple evacuation may lead to the
New vascular.
Because of multiple MTPs. Okay, thank you madam, very nice input. I put this case in Assam and Professor Nobis was there, a very respected, Bhaskar must be knowing him, a very respected person for us, and he put in also some very nice inputs like this. It was an empty normal uterus, no adnexal pathology, but the cervix showed an irregular echogenicity within the matrix of 1.5 by 1.5 centimeters. What is it? What is happening?
Cervical carcinoma cervix.
Can be a cervical pregnancy and retained plus products.
Not this time. Biochemical is all normal, madam.
All SCG levels were normal.
All normal. Absolutely normal.
PSTT. Placental side.
But madam, that should at least show some rise, no? It will not rise up to the level of 1 lakh and 2 lakh, but at least 20,000, 30,000.
This may be coincidental CA cervix which may be developing there.
But the cervix is apparently absolutely normal. जो कुछ problem हुआ वो side पे ही हुआ, खुद को तो हुआ ही नहीं.
Okay. So new vasculars, new.
Because of repeated MTPs.
Yeah, some new.
Madam, every time curettage was not done. Now drugs are available across the counter. Please speak on the mic because the audience is there.
Whether those MTPs were done by medicine or whether those were surgical.
We don't have reports, but she said that every time curating was not done. आप बताइए, माइक में बताइए प्लीज.
The last cervical MTP.
हमारे पास अभी 7-8 मिनट है.
So the last case was a cervical pregnancy.
She had, yes.
So maybe it was an incomplete MTP. If they'd done medically, maybe it was an incomplete.
वो cervical pregnancy को तो खत्म कर दिया, उड़ा दिया उसको. Some brilliant, like Alpesh, brilliant gynecologist like Alpesh was operating. We don't doubt his efficiency. Okay, you doubt mine, but not his.
Was she having other disease like sickle cell or thalassemia?
No, बिल्कुल नहीं.
Cervix had.
I know I have put you on a tight spot, but I have sent you the situations. And this was the one I knew is going to put on a tight spot, and it can happen. I have brought it because it can happen, can lead to mortality, can be a near miss situation. You want to know about color Doppler? I love color Dopplers. Correct? Shall we put in the power? Okay. A leash of vessels and vascularity suggesting an AV aneurysm not because of repeated MTPs but as a result of altered collateral circulation following bilateral internal iliac ligation. ये हो सकता है. ये हो सकता है. कभी कभी माँ भी मारती है, ठोकती है. माँ, मुझे किसी ने भी मारा हो, मेरे फादर ने तो मारा था पर मेरी माँ ने भी मारा था. माँ ज्यादा मारती है क्योंकि उसको ज्यादा दुख होता है इधर. Interiliac ligation is like mother. That was the cause. And this is true to life case. So thus internal iliac ligation in this case has probably brought about an anatomical aberration, possibly iatrogenic in nature. It can happen. Just as B-Lynch can rupture a uterus. B-Lynch can rupture a uterus. Methotrexate in medical termination of pregnancy can rupture a non-scarred uterus. ये सब बहुत अच्छे एंजल्स है, पर वो भी उनके भी साइड इफेक्ट्स होते हैं, तो एक्सेप्ट कर लेता है. एंड इफ व्हाई वी कम टू सच सेशंस इज टू सेंसिटाइज कि ये भी हो सकता है. डॉक्टर टेकचंदानी विल एग्री विथ मी. ओके, सो फ्रेंड्स, आई एम फिनिशिंग बिफोर टाइम. वो कहाँ गए टाइम मार्कर्स? ओके, मेनी टाइम्स वी फेस अपहिल टास्क्स इन आवर प्रैक्टिस, एंड दैट इज वेयर वी मेक a big blunder of trying to play a god, to become gods. Don't try to play God. No, just as I also did today, I asked for your help. And some of you correctly said that ask for help. Help me. Chillao, mujhe please help me. And today you as teachers helped us. You have really put in such brilliant inputs. Let me tell you, I have conducted this near miss at many places. Today I got some of the finest answers. I am really thankful to you. And therefore it is said, now wait, the time is coming. I am taking it to the climax. The best teachers teach from the heart and not from the book. That is the biggest challenge to we teachers now. In post-Google days, ये सब पढ़ सकते हैं आप. And Bhaskar was very humble in telling that all this is available on Google. तो फिर हमारा ये कॉन्फ्रेंस की क्या जरूरत है? कॉन्फ्रेंस की ये जरूरत है जो आपने हमको सिखाया. Such shock index पर डिस्कशन हुआ, such wonderful inputs we got on so many other points. And somewhere you also swaggered कि नहीं पता चलता है. Teachers also may have their limitations, and that is fine. And therefore, as a tribute to you teachers, I have made a small film of 1 minute. You have got 1 minute 50 seconds, and we'll finish in time. Ladies and gentlemen, please wait. You can clap for them after the film. Thank you. Now you can clap for them. Please clap for them. Thank you very much. Thank you very much. Thank you so much. Thank you very much. Thank you very much. Thank you. Thank you very much. Thank you, ma'am. Thank you. Thank you so much, sir. अरे बाप रे सर. They first tried to do this equalization.
It ran a dream.
Because very risky. Madam, this presentation will be on. What, madam? Madam, this presentation will be on my website next week. You can visit it, and there the whole thing, and drpankajadesai.com, and there you can question me. I will email you. drpankajadesai.com. मैडम ये मर जाती. इमोशंस एंड क्लिनिकल, फिर वही उसके रिलेटिव्स बाहर मारते हमको. वन चाइल्ड इज देयर. फोटो थैंक यू. Thank you. Thank you.